This patient, 65-year-old lady, she had knee pain since many years. So we decided to use max opulent system in this case, and robotic system was decided to use. The advantage of robotics is highly precise, and we can actually plan implant placement meticulously. Misso robotic system is a CT scan based system. So replacement surgery is not just taking out the worn out cartilage and putting back the metal piece in it. It is about restoration of this axis. And with this CT scan based system, we can mark these important landmarks, as I said earlier. And with the help of this, we can place implants precisely.
So now let's go on with the 3D reconstruction, starting with femur axis. You can see the head center, wherein it is automatically kind of placed into the center of the head on the sagittal plane and the coronal plane and the axial plane as well. So then you go to the epicondylar axis, wherein you see the medial and the lateral epicondyle, and this it is automatically populated, wherein the dots are perfectly placed in the center in both coronal, sagittal and the axial plane. Then you see the epicondyle, which is placed on the sulcus, and you see the lateral epicondyle, and following which you see the medial posterior condyle, where you try to place it on the posterior prominent part of the femur, and then you have the lateral posterior condyle followed by medial distal condyle and the lateral distal condyle. Once the femur axis is placed, then you see the medial lateral distal femoral angle, which is 87 degrees, and the transepicondylar axis, which relation to the PCA, which is 1 degree external rotation, and then you see the HKA axis, which is 179 degrees. Then we finally go to the implants, to see whether the implants are positioned well and also to see the sizes. Here we have got femur size E for this patient, and then on the tibia we have got size 3 tibia. Now if you want to kind of change the position of the implants, we have got enough leverage to kind of do it external rotation or keep it in varus or valgus on the tibial side as well as the femur side. We tend to kind of do the conservative cuts to start with, but intraoperatively whatever is needed to achieve the proper balancing on both medial and lateral side can be achieved following the final plan is approved. Now let's look at the final planning. Here we have got a tibial size 3 and the femur implant of size E, and I can see that there is no overhang of the femur. It is perfectly kind of fitting into the implant and to the femoral anatomy. Similarly, if you look at into the implant positioning, the 3D images, the femur and the tibia is well aligned, and also it has been covering most of the bony part. So with all this planning in place, I would go forward and finally approve my plan and go with registration intra-op to kind of implement my plan. And this is how the whole summary looks like.
Hello, so we'll be operating 65-year-old lady with knee osteoarthritis for left total knee replacement using Misso Robot. As you can see, the robo preparation is going on and the backstage. By the time robo calibration is going on, I'd like to show you some knee movements. So that's her max flexion and around 5 degrees of fixed flexion deformity, not much laxity in the knee joint, and so pretty much straightforward knee for total knee replacement. So this is little robo dance you can see here. Now the calibration for this particular case is going on. So this is a CT based robotic system where pre-op CT planning is done and that plan is loaded to robo, and before each and every case robo will calibrate for that particular case, and this takes around 10 minutes. So once the calibration is done, robo is ready and then we can proceed with the case. Typically while using robotics we don't need to touch the posteromedial corner. So putting these pins on the medial side is always recommended. The stab incision or minimally invasive, if you go and on the tensile surface, then might fracture. So this is absolutely safe. So when we start, so this is the tibial array, this is the femur array. Before you start, you make sure that all these arrays are secured properly and there is no movement. Everything should be snugly fitting there. There should not be any movement at all, because if it changes complete its 3D image, whatever is we are going to generate in the robo, it will change. So now it is good. This array position looks good and we are good to go. We start with the femur mapping now. Yes. 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 ठीक है. Yes. Final RMSE is 1, which looks good to me. Go to tibia. Yes. 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 0.7. So we post, yes. So this is size E, posterior resection 10.7 on the lateral side, and medial side it is 11.6 for size E. This looks size E, I mean this. So, and gap it is showing laterally 10, medially 9, so which looks good to me. So, and the flexion it is showing, it is around 112-15 degrees flexion, max flexion. So the left bottom you can see FE, it is a flexion, so around 120, 125. So it's a good flexible joint, but it is a flexible joint. So 9 is also acceptable in this case, and should be a good thing. Capture. Okay, so we can give touch of external rotation slightly. Fine. So extension it is showing around -6 there. It is almost neutral, but there is definitely slight hyperextension there. As you can see, there is no fixed flexion deformity, and so if it would have been a FFD case, then we would have kept the gaps around 10 or 11 based on the FFD. But it is already -10 it is showing. Clinically it is around -5, 6, 10, up to, you can stretch up to -10. So we can accept anywhere 8, 7, 8 is also good, because we will end up with 9 poly since there is hyperextension. So it is 7, 7, 9.4. What I would like to do here is I'll just increase my distal cut by a millimeter, and we aim for around 8 gap here. Okay, so we'll increase distal cut by a millimeter, because flexion it is already balanced. I don't want to touch tibia here because it will affect both the gaps. So looks good to me. Capture please. Looks good. And here flexion around 110 it is. So what we will do, we'll give 1 degree of external rotation. It's already 11.6. 1 degree. Okay, capture please. So it is getting balanced, 107 degrees, flexion 9, and extension 8. So all set, looks good to me. We'll go ahead with full surface resurfacing here. Proceed. We have attached these pins for the femur and tibia and these clamps. With this, patient's knee joint, patient's body will be attached to robo so that it should not move. So both those circles arrays should be preferably in the center of those circles. Start. Up this, you come on this side. So here, before we proceed, Nibbler please, like to verify, cross check what we have resected. So on the distal medial part we had planned for 10.4, okay, and lateral side we had planned for 8.6. So that's the beauty of the system, where each and every step you can cross check, verify before you proceed. That's fine. So that's the beautiful distal femoral cut you can see here. So after the distal cut, now we proceed with anterior chamfer cut. So now we are proceeding with anterior cut. As you can see, while taking the posteromedial cut, we really don't need to protect the medial collateral ligament there. It is going to stay within the bony boundary. That is the beauty of this haptic controlled fully automated robotic system. So this essentially cord osteotomy completes the femoral cuts. Start tibia. Okay. Okay. Capture please. Happy? Happy with this? बढ़िया एकदम नहीं नहीं एकदम अच्छा है कुछ नहीं इसमें ये देखिए check confirm see look at this ये patella tracking also patella is tracking beautifully so whatever we have planned we could execute thank you very much robotic surgery versus conventional surgery, this debate or discussion is going on world over, you can say. If you go through the latest research or literature, convincingly it is going in favor of robotic surgery. Why? Because it is highly precise, it is highly reproducible, it is like having good assistant inside operation theatre. It is like validating your own surgery before you take patient outside theatre. So these robotic systems, especially in orthopedics, can be divided into semi-automated or fully automated, or which can be based on a CT scan or non-CT scan based systems. So Misso Robot is a fully automated robotic system which needs preoperative CT scan planning, where we do 3D CT planning from hip joint, knee joint till ankle, and all these important bony landmarks are planned on CT scan, marked, everything is marked on CT. Based on this information, mechanical axis correction, whatever is required during the procedure, is calculated. Implant placement, we come to know a day prior to the surgery how this implant is going to be placed, how much bony resection is required. All these minute details, rather about the complexity of the knee joint, which we cannot see on routine X-rays, everything we come to know on CT scan. So once we plan it thoroughly, that plan is saved and it passed on to Robo on a USB drive. Once we load this plan, a customized plan for that particular patient's knee, Robo during the procedure validates our plan and confirms it and aligns it with the patient's actual bony geometry. Once the plan is approved during the procedure, still we can do some fine tuning for that particular plan based on the intraoperative conditions. Once the final plan is approved, Robo comes in and finishes all the required cuts in 8 to 10 minutes. It is highly precise and very fast. The cuts are done as per our planning, and cuts are planned in such a way that you need minimal soft tissue handling. So when soft tissue handling goes down, post-operative inflammation also goes down. That reduces post-operative pain, that speeds up post-operative recovery. So all these things are related to each other, they are interlinked. And Robo definitely helps the surgeon in placing these implants in a precise way, in a better way. We call them mechanical outliers. So definitely robo helps us to reduce these mechanical outliers. When mechanical outliers goes down, that implant placement is improved and that improves implant's life. So typically what the joint would last for say 10, 15 years, it will last for say 20 years, 25 years. So the literature in coming years will definitely prove all these points. So in short, as compared to conventional surgery, robotic surgery is highly precise, is reproducible, efficient and patient friendly.
What makes Misso truly extraordinary is not its precision and personalization, but its unmatched agility. Its calibration, verification, and registration combined with various cutting options to minimize tissue damage, enhance efficiency, making Misso a game changer in modern surgery.
So I'm very excited about the transformation Merrill is going to bring to the healthcare arena, to the medical practitioner, to the large corporate hospital, to all the parents, mother, brothers, sisters we kind of go to, because we see Misso as one solution which our surgeons are going to inherit into their practice. And I see every patient today or tomorrow being operated on Misso. So this is one big opportunity for us where we take India to the world.
In this journey towards a better future, Misso represents not just a technological marvel, but a beacon of hope and progress. We envision a world where healthcare is accessible, efficient, and transformative, guided by the innovations like Misso. Join us in the exciting venture as we pave the way for future forward, shaped by the promise of innovation and the relentless pursuit of a healthier, more connected world.